All right, thank you all for coming and actually traveling over here from North Ingalls to our panel discussion. So this is the execution phase that we talked about earlier this morning with our design reviews, our biweekly subgroup meetings, and we have a panel here of other programs that we have worked with throughout Michigan Medicine. And for each one, I'm going to ask them to tell you their name, their title, and then also what was their role with the clinical design program process.
Hi, I'm Scott Regenbogen. I'm the chief of the Division of Colorectal Surgery, and I was the physician lead for a clinical design project focused around the perioperative care for colorectal cancer surgery.
Hi, I'm Tiffany Luke. I'm a nurse practitioner in interventional cardiology. I was the process owner for improving transition of care from inpatient to outpatient with acute MI patients.
Hi, I'm Dave Wasorek. I'm a hospitalist, and I was one of the clinical leads for the CDI program in atrial fibrillation, quality improvement.
Try this one now. Is this working? I'm Gabe Owens. I'm the medical director of the pediatric cardiothoracic ICU within pediatric cardiology. I'm the physician lead for our design program at really looking at the perioperative care, but specifically surgical site infections in our congenital heart disease patient population.
I'm Amber Lopez. I'm the administrative manager in orthopedic surgery, one of the managers. We are working on the PROMS questionnaires for patient-reported outcome measures for better outcomes for surgery and orthopedic surgery. And we're in the middle of our project, so.
Yep.
Yeah.
She's one of the process owners.
Yes, process owner, sorry.
I'm Renee Havey. Is this going okay? Okay. I'm Renee Havey. I'm the clinical nurse specialist in our adult ED, and I've been working with them on our sepsis work in the ED.
So right now, what we're going to do is have this discussion. So Jamie is over here. She's got a mic. If you guys have a question, I'm going to start with one question, and then if you guys can raise your hands, and we're going to pass the mic around so you can ask the panel some questions. We also have two other individuals right here. We have Mark from our patient-reported outcome measures group and Diane Lopez for the acute myocardial infarction group. So everybody's going to be able to answer lots of questions for you today. So I'm going to kick it off with the first question, and I will ask Dr. Owens. So before engaging with clinical design and innovation, what has your experience been with process improvement?
Lucky the first one, huh? Excellent. I guess I initially would have said I thought I did have some experience until I went through this process, which has been, certainly eye-opening. I think from my standpoint, certainly have been involved in various quality improvement initiatives, sort of identifying a problem with our patient population and undergoing initiatives to try to improve upon that problem and improve quality. But now, having started the process, and we are definitely in the middle of ours as well, now in the technical design phase, that it was, quite an informative process to really understand what true process improvement is. It made me think back to some of my past experiences, shedding light on them and suggesting that maybe we weren't going about them the right way. The strategy, the organization, the stochastic measures that go down this pathway really give credence to the process, and I think it was really an educational and continue to be an educational experience for myself and many people involved in the program. So I think it was some immature experiences prior to joining the CDI process that we're undertaking now.
And Amber, I'm going to ask you the same question. So what was your previous experience with process improvement before engaging with clinical design and innovation?
So this is my first experience with your office. However, when I worked in psychiatry, we did a A3 project for our call center to find more lean and efficient ways to get the patient off the phone quickly. So we spent weeks and weeks doing that project. So it was a similar kind of thing where we did the value stream mapping and root cause analysis and all of that. So, but this is my first experience with this office.
All right, wonderful. All right, so questions from the audience. See, this is when you get your chance here. And also, there's stickies in your folders so that if you guys have questions and you don't want to forget it, it might be a good idea to go ahead and write that down. So as we continue to have this discussion with the panel, that you can get your questions answered. So who would like to be the first person in the audience to ask a panel a question? All right, perfect. And you can go ahead and say who you are and where you're from. That would be helpful, please.
I'm Constance Collian with Blanchard Valley Health System in Findlay, Ohio. What was one of the best things that you felt that the CDI team did for you to help you and the rest of the team do the work that you needed to do? Was there ever a time where you had an aha moment of, wow, I'm really glad we talked about X or we did Y? You know, have any of you had any experience like that?
So Amber would like to go first. All right.
I personally think it's been enlightening to have their help because, you know, when you're doing projects like this, trying to find improvements, I think having their guidance and them kind of coaching you along the way has been really helpful because they've kind of pointed us toward things that we may not have thought of. And like I said, we're in the middle of our project, so we still have a long ways to go, and I think it's going to be really great because I think we're going to make some huge improvements. So
I think I would maybe point to two things that were different about this experience. It's a little bit almost to your first question, but more directly to yours, that were really useful and efficient and effective in the process we undertook. The first was being forced to have a little bit of kind of diligence and care about looking at the picture from the very start. So not being allowed to jump directly to what I wanted to talk about and what I thought I wanted to focus on, but instead being forced to have a little bit of careful attention to starting with a very early value stream map, starting with a very careful step-by-step thought of our entire care process, which then ended up changing our focus a little bit. Gave us different periods of the path of care to focus on, and I think allowed us to pay some attention to things that we would have otherwise probably ignored. And then the second was what the CDI team kind of brought to the table was a real variety of people with different exposures in the health system and people who were willing to really get under the hood of how things worked. So for example, when we wanted to create a order set that would get our patients all the way from the office to discharge after surgery, it turned out that required 6 different kind of component order sets within our electronic medical record. And so to have people within CDI who were willing to figure all that out, hunt down the actual people who were responsible for making these things happen, and make sure that their attention was paid to us for enough time to get the work done. So had I been doing this on my own or via our usual pathways, I think we would have skipped over a lot of important steps, and I think we would have never actually gotten access to the real people who could make things happen the right way.
Yeah, I'd sort of echo the organization, the efficiency, and then really the diligence of staying on track and really keeping our team focused. I think, certainly as a clinician, I wanted to jump right to the solution right from the beginning. And I must say that it took a lot of patience early on to go through this process so diligently, as we were guided to do. And I think my role as a physician lead was helping disseminate some of the patients I was trying to hold on to the rest of the group. And then those aha moments do start coming when you see the months of work that you've put into it, being patient and really trusting the system start coming to fruition, and seeing groups of people coming from all different aspects of your care teams and the hospital setting come up with really great ideas to get us moving to that next phase. And I think, really just buying into the system and really trusting it. I think trust is a huge word going through this process, is something that I really identified early on in the stages of our path.
I would also elaborate on that as an outside, unbiased team. they asked a lot of uncomfortable questions that we otherwise wouldn't have spoke about in the room because of who you're working with. So when they ask questions, well, why do you do this? And they're asking us. And so we had to go through and uncover a lot of things that probably would otherwise be uncomfortable and start figuring out, why do we do these things this way? How can we make change? How can we, take the opportunity to assess what we really should be doing? So I think that was really helpful to have a non-biased person step in when they're not even familiar with colorectal cardiology, all these different things. They have no idea about, the clinical aspect of it, but they're about process improvement and trying to improve our processes and really make things efficient and actually improve patient care. So I think that was really important.
Anyone else? Renee?
I would echo everything that my colleague said. Their persistence was amazing. Our project would not have gotten to where it was without them by any means whatsoever. The resources that they had available and the way that they were able to seek certain people out to meet certain needs was awesome.
Another question from the audience. Okay, Jamie, you want to ask the next one? Yeah. We'll keep it rolling here, and then you guys can think of more as we continue.
All right, so Dr. Rousseau, this is for you. What was your initial thoughts when you started with CDI, and what are your thoughts now that you've worked with us?
Is this working?
Yeah.
Okay. Well, so it's interesting because we started to do this atrial fibrillation project actually as a departmental project without the help of CDI, and so. And there were some changes in personnel and sort of, I think there was institutional interest in the questions of efficiency around atrial fibrillation that sort of got it moved into the CDI area. And so I think I have a kind of unique perspective on starting something without this system and moving into something that sort of was within the system of CDI. And so. When we first started, I guess I'm always a little skeptical of new kind of things in terms of quality improvement, and so I wasn't sure how that was all going to work out. But I think what the others have said here is I think very important, which is that the CDI brings a system to the process introduces a formal process that's very helpful. Without that, I think you tend to fall into sort of areas where you may miss things or sort of not take a holistic approach to the problem. And so yeah, I think I would echo the same thing. I think probably the thing that I'm most impressed with is the fact that, and this is kind of true of quality improvement projects in general. Once you sort of have you may have an idea or you may see a problem, but until you have a team of other people that sort of look at it the same way, you feel like you don't have a whole lot going on. And so once you get a full team, whether it's CDI or anything else, that really is almost the momentum that makes the project move. And with CDI, you have really committed people, and so I like the thing that I think now that I've kind of gone through, we've sort of done part of the AFib project that was related to the emergency department and improving, decreasing the number of admissions for AFib and improving sort of follow-up in a rapid follow-up clinic. We've kind of mostly gotten that part done, and now we're kind of working on the inpatient side. And what I've learned kind of from the ED side is that that persistence that we're going to keep meeting, we're going to keep on this until we sort of achieve what we're trying to achieve has really been helpful. So, it's one thing for a bunch of clinicians to try to think about problems, and that I think that's oftentimes where the problem identification starts. But sometimes clinicians just don't have all the quality improvement skills to sort of put this whole process together. And that's where I think having, an industrial engineer, a project manager, and the ability to tap into other resources in the institution is really very useful. So that's kind of my before and after perspective on that.
Excellent. Thank you. Yes, we have another one.
So my name is Fletch Corbett. I'm with Munson Healthcare. Just joined their team as a continuous improvement specialist. So now that you've gone through a CDI project, how are you taking your lessons learned back to your practice? And are you looking for future opportunities, or how are you looking for new ways to improve your overall practice?
Any takers to be first?
So I would say we're still towards the middle end of our process. And I think that having the number of staff involved that we did and having a good team involved, it opened a lot of people's eyes to different ways to do things. So I think we can really kind of capture that and help people recognize, like, okay, we can use this tool to look at this problem. So we haven't really done anything outside of the sepsis work yet, but I think it has definitely opened our eyes to tools that we can use later.
And we're currently we finished our process, but we're in the sustainment part of it. And so with that, we're still collecting data, making sure we're meeting our goals with sustainment. So I haven't really looked outside of what other opportunities, because we're still trying to make sure we're sustaining our current goals that we have in place. And I think it would take a while for every process, because we implement all these changes and processes, but we have to make sure that they're sustainable and keep collecting data and making sure that we're on track. And I think that takes time. I mean, I think it probably takes years to make sure that we're sustaining our objectives. So that's currently where we're at in our process, that we're sustaining what our objectives were.
I think another thing that's becoming apparent is that it's not just sustaining those processes, but sustaining the personnel to do it. And I think that one of the things that I think our group is learning as we're going through, and we're sort of in the middle stages, that to continue this, to sustain it, and to identify new areas to improve upon, we're going to need to get specialists to help us, like the CDI or like folks in this room, to join our team, maybe on a permanent as a permanent fixture, so that we can continually improve our processes.
I think to the point of your question of, what do you do after you think you're done? I can share maybe something, I don't want to say a mistake, but maybe a place where we didn't think quite ahead enough. So our project was one of the very early clinical design projects, and what we probably didn't do that well in the first go-round was we didn't have a plan in place for ongoing data collection, really. We didn't have a really sustainable surveillance plan for how we were going to get going afterwards. And so when we started to wrap up and get towards where we actually had things ready to be implemented and to go, we actually didn't have a great plan in place for data collection. So we did it, but we were a little bit behind. And so I think the mistake was being ready to go live without a real plan for assessing our success, because it's been really important now to be able to have sort of an automated, computerized, easily accessible data stream that doesn't depend on the army of people who were helping me out before.
Hi there, I'm Diane from cardiology. I work in the cardiac ICU and nursing in the step-down area, and so we've been on this journey for about a year and a half, I would say. And I mean, starting from the beginning to where we're at now, I mean, we've taken great strides. And so the details of things from the start and having a multidisciplinary group has been really eye-opening and beneficial, because from a nursing standpoint, what is important to us, we might not realize how something else is important to the other team members. So identifying any type of barriers and solutions from start and then going all the way through has really been beneficial, as well as eye-opening. And the team helps to execute all of that.
Another question from the audience. All right. Perfect.
My name's Ed Pocock. I'm with Smith Group. I'm an architect and a healthcare planner. And I know probably most of your problems or design solutions are all in process, but from a selfish point of view, I'm wondering, how much of your problems are built environments? And do you see that as something in any of the projects that you're involved in? Give some examples of some built issues that you work to resolve.
I'm not sure if this answered your question, but how I think of your question is, with this as a large academic institution, and with the house staff, we have a lot of, they're always rotating through, and there's challenges with educating them about our processes that we put in place. So for an example, to sustain what we did with the ongoing change with the house staff from month to month on the cardiology services, our M-Plan leader, Dr. Stein, has a monthly meeting with the house staff and has a whole list of objectives about cardiology, and not specifically just to our process, but in general of what their needs are to take care of the patients on the cardiology floor. So he implemented a monthly meeting with the house staff when they rotate on the cardiology services. We created a discharge dot phrase to go into the discharge summary, so they're all educated on that. So from the inpatient discharge summary to the outpatient providers, it's a clear, concise summary of what happened on their hospitalization, rather than digging through, and it's made sure that we hit all the key points and what medications and what they actually had done. So knowing that this is an academic institution, there's a lot of transition between attendings, between interns and residents. We knew that we needed to find a solution that we can pass on what our needs are, what our objectives are on a monthly basis, because that was part of the barriers that we had, was the ever-changing house staff, and how can we keep everything consistent and sustain what our objectives are without having such process and plan in place.
And it seemed like you were even getting curious about the physical plant, the buildings themselves. I mean, it's not a huge thing that came up, but Jamie might remember when we were talking about it, but I mean, we were having discussions, and we're looking at surgical site infections after heart surgery. So going through all that process and mapping out how a patient gets referred to surgery to the recovering, we talked about everything, including one little ridge on the hallway floor, where every time the OR takes a patient up to the PCTU, they bump this ridge, and lines get tossed, and IV poles start falling over, and all these things that are identified, and people have known about this for, I don't know, we've been in the hospital since 2011, but we start thinking about, does that cause a vulnerability to our patients? It very well may. Is it the one cause that causes a surgical site infection? I don't know. They'll help us figure that out. But I think that we've uncovered simple things like that, or the location of where our ORs are related to our ICU, related to a hybrid cath lab, related to different places patients travel. So I think that is something that was surprising to me, that things like the physical plant and just our environmental exposures sort of come out in this process probably more differently than they would if it was just a bunch of clinicians sitting around going, do we need to use different antibiotics or something like that? So.
In the emergency department, we're a very large ED. We have 90 physical beds in our department, and it's separated across 6 different patient care areas. So there's a lot of providers caring for patients at all times. So a lot of what we did was leveraging the EMR to help us reduce wasted movements. So an example would be if one of our nurses was in the back of what we call our east area, a lot of the antibiotics that come from upstairs go to our pharmacy, which is an easy 90-second walk, which doesn't sound like much, but if you're not sure if your antibiotic came down or not, and we don't have a good way of knowing, you could be walking back and forth to that several times. So when the order goes in, we created a page to that nurse so that they would know, okay, now I can be on the lookout for it and it's going to be coming. So using things like that to our advantage, because we really couldn't do much with the physical space that we had, but we could make it easier for people.
Yeah, the physical plant kind of stuff, it's interesting because it's not something that I think clinicians would really think much about a lot of the time. But in the AFib, on the inpatient side, one of the things that we realizes that there's significant physical plant issues with the size of the EP lab and rooms designated for certain procedures that really have caused backlogs in terms of the ability to do things like TEE cardioversions, which require some coordination and things like that. And so it was kind of off our radar, but when our industrial engineer and our project manager kind of went there and they watched the process, something that's sort of kind of foreign, I think, to a lot of people, but really becomes important in a sort of a lean sort of approach. They realized, well, part of the problem is just the physical plant here, and so I think those things become obvious if you have the resources to sort of go look.
Chris Weisbrod with Catalysis, and as part of my role, I travel to a lot of hospitals within our network, and the one thing, opportunity I see quite a bit is these impenetrable silos sometimes between PI, clinical quality, patient experience, infection control. They're all working on kind of the same things, but not together. It doesn't seem, how did you guys get around that, get through that? Because it seems like it's a very collaborative effort here.
I'm Mark Castarillo. I work for orthopedic surgery. I'm a systems analyst for that group, helping them facilitate the PROS implementation. So we've encountered this problem in our department, and what CDI has offered in terms of value is their network within the health system and their willingness to learn processes that they have never encountered before. So apart from their tools and their network, their persistence and being able to set up meetings with these silos to try and break down their process, because sometimes even before setting up a meeting, you have to fill like 5-page paperwork just to set up a meeting with this group. There's already a lot of barriers, but they're very persistent, and they'll check all the boxes to try to learn and understand this silo's interests and priorities, and the network that CDI has enables them to sort of, I wouldn't say subvert, the silo, but usually their network is pretty good to find angles in which the silo would be able to comply and provide some assistance if they're blocking your process or the way that you want to do things. So that's my experience so far.
The only thing I would add to that is that I think that the way that the CDI group has helped, bridge those silos is really knowing the language and making sure that they're inviting those folks from different silos to add value, right? If you're inviting people to sort of break down the different silos, but you're saying, hey, you're bringing value to this process, people are much more likely to participate. And I think that's a skill set that the team brings to our group, is knowing how to, invite people the right way and invite people to add to the conversation rather than just invite people to invite. And I think, identifying what value different groups can bring to the table is a really important aspect of what they do.
Get my workout today.
Hi, I'm Mary Beth Morrison from Traverse City, Munson Healthcare, and I'm wondering a couple things for the panel. One, what are you proudest of that your team accomplished? And did any of you experience and be willing to share where you thought you were sure you knew what the problem was and you found something very different?
I'll take the first one of those two questions. One of the things I thought was that I'm kind of proud that we accomplished was, what we kind of identified is that in the emergency room, a lot of people were with atrial fibrillation, low risk atrial fibrillation, were being admitted because it's just kind of what we always did, and the care is complex enough around those folks that it is hard to just sort of get that all tidied up in the ER and then say you're good. And so what kind of came up as the solution to that is if we had sort of a quick follow-up, and it had to be pretty quick, like within a few days, so that the ED people could, sort of be unburdened with the idea of like starting anticoagulation and having perfect rate control and all the things that sort of make it kind of dicey to sort of manage these folks in the short term. And so one of the things that we were able to do, kind of with the help of CDI, is kind of go to the administration in the cardiovascular center and say, what we really need is a clinic where we can follow these people up within a few days, and not a huge volume of people, but enough so that it required really sort of assigning a mid-level provider, advanced practice provider to sort of have this as something that they actually do on a regular basis. And so it was a financial commitment, and really working with the administration, we were able to come up with a way of sort of showing that actually paid dividends in the end. So like this thing that seems like it's like one little add-on clinic that's costing someone some money is actually really paying off in the end. And that really was sort of the foundational kind of thing for the whole ER project, was having that new sort of ability to sort of say, all right, we've done initial care here in the ER. Within a few days, you're going to be seen by an EP specialist, and both patients really thought that was ideal because patients don't particularly care for being admitted for 2 days and having 10 different providers come in and think about what they're going to do. They like the streamlined nature of it, but it also sort of, I think, really helped us achieve our goal of having less people be in the hospital for a short period of time. So I think, and that was, I think, something that I think the CDI folks really helped us by sort of knowing, bringing the team together, having the administration of the cardiovascular center involved, and knowing how to sort of negotiate something like that. So it's something that could have easily been like, well, we just aren't going to be able to do this. We don't have the resources, but we actually were able to kick it forward. So.
Maybe I'll take a little of your second part of the question of what something I got wrong. So surgeons were known for complaining about the time between operations. That may not be a surprise to you. And so as part of our project, it was actually a bit of almost a little offshoot of our main focus. We did a bit of a deep dive into kind of throughput through the colorectal surgery ORs, and it really turns out that. Sure, we could do better with all kinds of things, but actually we spend the vast majority of our time actually operating. That maybe is not at all surprising, but to some degree what it made us realize was that if we wanted to improve our throughput, we couldn't just gripe about turnover. We had to actually pay a lot of attention to what happens during our time operating. And so it actually forced us to change our focus or just look at different things. And so what we ended up looking at more than anything was the consistency with which we were in the same locations in the OR and the people we were working with. So we learned lots of things about turnover, many of which were helpful, but we learned about in the operating room itself, for example, over a 3-month period, the 4 colorectal surgeons had 61 different circulating nurses work with them. And that was clearly going to result in a bunch of people who were not going to really know in a very efficient way how to carry out those operations. So again, it was the sort of age-old assumptions about how things work in the operating room, all of which were true, but were only a tiny part of the story.
From a patient perspective, we did this. I'm really, really proud of the processes that we created. We had 5 subgroups with improving transition of care for people that have a myocardial infarction. The one that I focused on, at least that I participated in, other than being a process owner, was following the guidelines and getting patients seen within 14 days of leaving the hospital. It's actually American Heart Association guideline after myocardial infarction to get these people in and get them seen, make sure they're transitioning well after having a heart attack, their medication compliance, and that they're just overall doing well, and that they're just improving. So on that end, I'm the one who actually follows these patients afterwards. And so I actually got to see from a patient perspective how they're satisfied with what we've created, because there's a lot of anxiety around when they leave the hospital. It's very fast paced. They actually get a patient education folder, but as you can imagine, they're just overwhelmed with with the whole process, the diagnosis, they're still in shock that they had a heart attack. And so to actually circle back around within 7 to 14 days and summarize what actually happened, because a lot of times they don't even remember. They don't remember that someone said their heart function reduced. They don't understand what medications they're on. They're actually very, very happy and satisfied, and they thank me all the time for getting them in sooner, because the anxiety level is so high. And actually the readmission rates, the 30-day readmission rates is really high for non-cardiac symptoms. So what they think may be cardiac, because they're so hyper aware and they show up to the ER, use resources where in fact they're not. So they just need a lot of reassuring, reduce their anxiety, and overall that's what improves patient satisfaction.
The other things that, as Tiffany had mentioned, that we're really happy and excited about is the improved collaboration between nursing and physicians. And now that we have these monthly meetings, areas are addressed specific to order entry, so physicians are getting paged much less because we were able to discuss this at the beginning of the month and each month thereafter. So frustrations are much less, so we're pretty excited about that, and we've got excellent feedback. The other thing that we're really proud of is the work that we've done in regards to patient education. So the team had helped get information from other institutions across the country to ensure we have the most current and up-to-date information for our patients. So they were able to facilitate that, and we were able to look to make sure we're meeting the needs of our patient. And we also had patient involvement to make sure that it's something that they are able to read and understand. And we were also able to streamline the patient education in my chart so that what's in the booklet is going to match what they're going to be charting, as well as there's going to be a prompt to remind nursing to make sure that you have that education book. So we're excited about that as well.
Before our next question, I'm going to quick have Dr. Deeb introduce himself. Can you please tell us who you are, your title, and your role in the clinical design program?
I'm sorry I'm late, but I already had a pre-scheduled event that I had to be at from 10 to 11:30. My name's Dr. Michael Deeb. I'm the Herbert Sloan Professor of Cardiac Surgery. Our involvement in this is basically has to do on many levels. The first is patient care, patient outcomes. The second is financial for the institution. Clearly, cardiac surgery, specifically coronary artery bypass, is now a bundled type of payment. That means you get a box amount for what you're going to do, and that includes everything within the patient's care, including if you send that patient to an extended care facility. That comes out of what you do. It's also tied into what your outcomes are. So if you get paid for coronary artery bypass $32,000 and you send the patient to an extended care facility, and that's $10,000 of it, that means you had $12,000 for that whole thing. And oh, by the way, if you had an infection and that patient had to go back and have something done, that comes out of the $12,000. So the way of the future, I think, for healthcare with reimbursement is going to be bundle type payments. And so the best way that you can assure that from a financial standpoint, you're not paying the third-party payers for the honor and privilege of doing the surgery for them. You're going to have to be very efficient. You're going to have to be very effective. To get the honor of doing that surgery for them, you're going to also have a high ranking for outcomes and patient satisfaction, and that goes into what we call and these outcomes are going to be reported. I don't know whether any of you are a sports fan, a baseball fan, but if you turn in the sports page and you read the box score, you know what the batting average is for that player. Well, guess what? They're going to know what the batting average is for that surgeon and that physician and that nursing team. So you're going to be out there in the newspaper and everywhere all day, and people are going to look and say, it's like the manager, well, I'm not going to put that guy that's batting 250 in the lineup. I'm going to put the guy that's batting 400. And you're going to have heart surgery. You're going to say, well, I'm not going to have the guy that has 1 star. I want the guy that has 3 stars. So your ranking goes into that as a physician. Also, your hospital ranking goes into that. You know, everyone's really proud that our CVC is in the top 10 ranking in the United States. Well, that goes into your star ranking. So as your star rankings fall, all these things go. And so it's very important that we are efficient and effective in our care for many reasons. First of which is patient outcomes. Second is financial. Third is for your overall rankings and the prestige of your institution. And in a way, it becomes a sort of a circular type of a mechanism. You have care, and so you get a process of what we call best practice. And that's going to be based on evidence-based decision making. You're going to look at, if you have a process where you look at the patient from the time they enter to the time they exit, and you look at your quality outcomes, and your quality outcomes aren't where you want them, then you're going to start going back and reviewing and saying, where in this process do we have our most failures? Okay? So that's called quality assessment. And then what you do is then you say, well, we really are not doing well in our early extubation or our fast-tracking extubations. It's leading to pneumonias, it's leading to infection. Then you say, well, we're going to have an initiative and we're going to do something that's going to change this, okay? So that's your quality initiative. And then you're going to follow these patients, and then you're going to look and see what your outcomes are. So now, if you've improved outcomes, well, you've done your number one thing. And if you become more efficient and effective in your rapid extubation, you've done a second thing. You've increased your efficiency and helped your cost. So I think these things are going to be standard of care. We're going to have best practice standard patient protocols, which will give us a way of making an assessment, initiation, and an outcome.
Thank you, Dr. Deeb. All right, question?
Hi, Sam Rousseau from ProMedica Health Systems in Toledo, Ohio. Of all of the tools and approaches and steps that you've become acquainted with in your projects, what has stood out as a gold star in terms of being useful to you and to your teams in getting to a desired outcome? And what, on average, has been the timeline that you've experienced from either project concept or initialization to, say, the first blush at a successful design experiment?
Well, the first thing is you make people aware. Okay? The fact is that you actually are committing yourself to look at your process, look at your standard of care, and look at your care delivery. And you actually are going to analyze it instead of saying, oh, we're the leaders and the best. Are we really the leaders and best, or do we really stink at this? So let's look at this. So when you become aware of a problem and you start to look at that problem, that has a big impact. I'll give you a typical example. Transfusion rate for coronary artery bypass at the University of Michigan, heart surgery. When we looked at it, we were the worst in the state. And we would have just kept on doing it. And you know that there's a negative impact on correlation between the number of transfusions and the outcome of the patient. Once we started looking at that, within 6 months, we were the best in the state. Why? Because were we better than everybody now? No, we actually looked at it and said, wow, well, do we really need to do this? And why are we doing this? And can we all agree that this isn't right? And if we take this initiative and do this thing, it'll be better. So I think that ignorance is bliss. And once you understand what your practice is and what you're really doing, I think that it's really great that we have assessment now. I think it's very important that everybody's transparent. I think there should be public reporting. Okay? You don't want the lousiest car when you buy it, right? You want the best car. And they have to have out there public opinion on the car, and somebody goes in there and they, You know, when you sell your car, this says the power something or other, best car performance, right? Well, when you go to have heart surgery, you don't want the lousiest surgeon and the stinkiest hospital and the guy that's going to transfuse you the most, correct? And I don't want it for me, so why should I do it to somebody else? So it's all a matter of transparency, assessment, initiating something better, checking your outcomes, getting everybody on board. Okay, and the best way to get a surgeon on board is to put up there and go, you get a 96 and you get an 85, you know? A guy has the 85 and then 2 months later is gonna have a 98, okay? Because they're competitive people. And so it's okay to have public reporting. It's okay to assess what you're doing. In fact, it's proper to assess what you're doing, okay? If you take the Hippocratic Oath, you want to do it. If you took the Hippocratic Oath, you may not want to. But it all depends. And so I think just looking at it is the most important thing. That's what got the gold star.
I thought one of the most useful tools that we worked with was just a very simple grid of effort versus impact. Was really helpful to us because I'm sure you can't see it from where you're sitting, but I've been glancing over my shoulder at a poster that was sort of summarizing some of our work. And when we put our value stream map together and we put little stickies for problems we wanted to work on and things we might do, you know, we had a stack of stickies this tall. And so the question was which ones to actually pay attention to. And that was a really quick and efficient way to decide what were the quick wins we should just do and get them done with, and what were the things that were going to, you know, be quagmires we'd never get out of, and then focus our real energies on the things that were worthwhile but we're going to take some work.
Yeah, and I think the respect for the process and not jumping ahead like we talked about a little bit, you know, jumping to the solution, because I think to the second question from our colleague up there about, you know, is there something you really thought it was going to be and it was something else? Well, we're still halfway through and I still am pretty darn sure I know what it is, but I'm going to let the process and respect the process and see what happens.
How about timing, project time?
So ours took a really long time, and it was partly it was two things. I think first it was a little bit of the just early on in the clinical design experience. So sort of learning how to go about this, and I think they did a bit of a you know, PDCA on the process that we went through in our clinical design program, and part of the conclusion was they needed to accelerate the timeline. The timeline was largely driven more than anything by just my own unavailability, which was they were trying to not swamp me and trying to respect my other kind of commitments. But what that meant was that we just didn't move ahead quickly and we didn't meet often enough. And so I think, I imagine hopefully in projects that have come after ours, the timeline's been shorter, but it took us probably 2 years from our first sit down to when we had even just like a real plan in action, and then probably another year before we felt like we'd really done anything.
You know, I think after that, those sort of revisits and redesign, I think our initial timeline from inception of the project was 18 months. Is that about right? It's that sort of implementation and handoff. And I think right now we're sort of right on schedule. You know, we started our technical design groups right when we were anticipated starting that back when we designed the time frame, you know, back in March, April. So I think that the CDI group has done a great job investigating how they've worked with other teams and other groups in the past, and have done their own process improvement along the way.
I think one of the things that you have to understand is, I don't know about what you're in, but cardiac surgery is a team sport. It's not like track and field. It's like football, 11 players in there. You have nursing, anesthesia, you have all these people. So you have to coordinate everybody's schedule and you have to get people there. So that's difficult. I don't see this as a quick thing, because you don't want a quick fix. You want a good fix, because this has to reoccur for a long time. And even once you get this process in place, guess what? You could spend 2 years to get it, and in 6 months it could die out unless you have an advocate. You have to have somebody that this is their thing, and they're going to follow through on this, and they're going to make sure it gets done, because there's a lot of people out there who really don't want to do it. You know what I mean? And I think the biggest obstruction that we had when we began was there's two different languages, okay? There's medical language, and then there's these supply engineers who come in and they start asking you all these questions, and they put up all these flow charts and things. And so I think it takes a while to learn what this vocabulary is, and we still have some difficulty with that. So this is not, I don't know what your experiences are and what you're doing, but for us, this is not an easy process, okay? And it's not one that you can do in 3 meetings. It's going to take you at least a year or so to build something that has strength and that people are going to become stakeholders in, and that you can enact, and it can be purposeful.
All right, I have one last wrap-up question for everybody. Can you give me one word or maybe like a very short phrase of lessons learned from working with the CDI team? We'll start with you, Dr. Deeb.
I'm not going to choose the phrase. So I would say the main phrase or sentence is just the importance of getting all of the key members of the team in one place at one time to think through all of their roles in solving a problem.
I guess to come off that also is the efficiency, is process development, ways that we could do things differently outside of the box. When, like you said, when we get clinicians together, we kind of all think the same way. So when you actually get somebody on the outside to think a little bit differently, especially with industrial engineers, they help the process and help you come up with more creative ideas that you may not have otherwise came up with.
I guess I'll choose the word persistence because I think the persistence that CDI has brings to these projects is really probably the thing that drives them to their completion, which is maybe the biggest advantage to having a program like this. Is I think a lot of times people come up with ideas or recognize things that they could improve on, and maybe even start to make moves towards that, but without having something that's official and that's sort of I think a little bit of has the institution behind it. Those things tend to sort of fizzle out or not do well, and so I think that persistence that CDI brings is really one of the big assets.
Trust.
I'm going to say investment, the investment of time, because it takes a long time, as you're hearing. And I had Heidi and the team come to my last clinic staff meeting to engage the whole team, because they see that we're having these iPads travel the clinic, and they know the purpose, but I don't think they entirely understood the purpose. So having the team there to explain it all and then engaging all of them takes time. And we have lots of schedules to work around, from the surgeons to the staff, so investment of time, I think.
I'm going to say grit. I think when you combine the passion of the clinical design team in improving quality and the clinicians and wanting to improve patient outcomes and just that persistence that was already mentioned several times, it just really pushes you to get things done. So I would say grit.
I'm not going to give you a word. I'm going to tell you a couple words to eliminate. Number 1, no. Number 2, can't be done. Okay? We don't accept no, and we don't accept can't be done.
Perfect.
Go ahead, Mark.
I think measuring user experience for our project, patient experience is very important, as well as the provider's experience in the process. We invested in finding a patient representative to sort of consult with, but also looking forward to seeing how our changes improves the patient experience with the whole process that we're doing on them.
And I'm going to say execution. So it's very collaborative, multidisciplinary, and all the key stakeholders in one place trying to come up with a solution because we all touch a patient in some way, irregardless of our role. So the execution and helping to facilitate that.
All right. Thank you so much. If we can thank our panelists for spending an hour of their day with us.